Okay, welcome everybody. Thank you for joining me this evening for our BTOG webinar, this time on advanced radiotherapy techniques. And what we're hoping to cover tonight is some important tips and tricks for challenging cases. So I'd like to thank Dawn and Gina, who've really helped put this together, and welcome on behalf of the whole BTOG team for this evening's programme. So just a bit of housekeeping, please do submit any questions as you think of them by typing them into the control panel, and I'll be storing all of these up for the Q&A at the end of each of the three presentations. Also following this evening's webinar, you'll be sent an email for your feedback, which we really like to receive so we can better improve on further webinars going forwards. Once you've sent in your feedback, you'll be sent your certificate of attendance. And for any of your colleagues who haven't been able to join us this evening, who would be interested in looking at this online, please do remind them that if they access it in the next 4 weeks and use this RCP approval code, they can use it for their CPD diary as well. So this is the lineup for this evening. We've got 3 talks looking at advanced radiotherapy tips and tricks, firstly in early stage disease, then in locally advanced disease, and then finally all we need to know about SRS in the metastatic setting. So without further ado, I'd like to introduce Matthew Hatton, our first speaker. He's a consultant and honorary professor at Weston Park, and many of you will know him well. So I'm going to hand over to him now to give us some tips and tricks on what he's learned with the SABRE rollout for lung stereotactic treatment. Thank you, Matthew.
Thank you very much, Fiona, and thank you to BTOG for the invitation. So what I'll be covering is some information from the rollout programme that's introduced lung cancer SABRE to all centres across England. Part of that was, sorry, these are my disclosures. So part of the requirement was that there was a QA programme to ensure that SABRE is delivered to a satisfactory quality. My role in that programme, I have to say, is extremely modest, and you can see from this slide that an awful lot of organisations were involved, and I will give my particular thanks to Patty, who did an awful lot of work, particularly on the QA side, and helped me prepare these slides. So the SABRE expansion programme was set up so ensure that all English radiotherapy centres were going to be able to deliver SABRE treatment, both for lung primaries and also potentially for lung oligometastasis. This was an NHS England initiative, and they have, I think, achieved the goal, and I think all centres are now capable of delivering SABRE. Networks were involved to draw up plans for service provision across regions, and the RTQA group coordinated a radiotherapy QA programme with the help of the UK SABRE Consortium, who supported the outline reviews and critiqued the volumes coming in. In addition, there was a dosimetric audit, which was run by the National Physics Laboratory, and there is a mentoring programme with the CTE centres mentoring the newer centres to help them on their way with a few little tips day-to-day running of a SABRE service. So just thinking and focusing on the RTTQA programme, there was essentially 4 components: a questionnaire to assess what the centre had in place in terms of equipment and resources, and what they might need to get in place to ensure that SABRE could be delivered safely and effectively. There was a benchmarking exercise for the oncologists to check on their ability to contact target volumes and the organs at risk. And there was a similar planning benchmark process for the physicists and treatment planners to ensure that coverage of target volumes was optimal and sparing of organs at risk also optimal. And finally, as mentioned before, there was a dosimetric audit. So what this talk very much focuses on really is that outlining benchmark. So just to go through what the benchmarking exercise was, the RTQA sent out some packs with documents giving a clinical scenario, scans, 4D scan with phases, and a average image and a MIP image, and some instructions on what and how to contour. So they wanted in return some structures, targets, the GTV, MIP, and ITV, expanded into a PTV, and a particular focus on organs at risk. So brachial plexus, the proximal bronchial structures, trachea, the heart, the esophagus, spinal cord, and normal lungs and chest wall. The aim was to ensure that 2 clinicians at each centre passed the QA exercise, and those clinicians were enabled to cascade training to others within their centre that required it. So in terms of numbers, 24 centres took part in this SEP programme, and 47 clinicians have been assessed and QA'd. The pass rate on first submission, unfortunately, was very low. I'm afraid that's as much detail as I can give, because I think they're preparing some further presentations at the UK SABRE Consortium meeting, and hopefully perhaps at the BTOG meeting in January. And when we're talking about pass rates here, what I'm talking about is not necessarily the minor deviations that we will all see in our day-to-day practice, but major deviations. So changes or things that were far removed from what was ideal. So in terms of instructions, centres were asked that they generate an ITV according to the local practice. So if they were using breath hold techniques, to carry on using breath hold techniques, carry on doing the things that they're familiar with, and then grow GTVs using the average scan. Other centres that were using other methods for controlling of breathing were encouraged to do those, and contouring on the MIP and including individual breathing phases. So eventually you would get a structure recorded on the average that could be grown into a PTV. So looking at some of the results. So this is the primary tumour that centres were asked to outline. You will note it was a relatively straightforward tumour in that there were no speculations. The general criticism is that centres, clinicians tended to under-contour. So although this looks very nice in these images, what you need to remember is that these images are average images and are not really taking into account tumour motion. So what you have in general as we go through these slides, the red contour will be the sort of agreed gold standard contour, and the yellow contours are examples of some of those contours submitted by clinicians from the various centres. So not everyone under-contoured. 1 or 2 people got a little over-enthusiastic. The main problem, I think, with over-contouring was very much sort of contouring of vessels. So I think this is something that can be a little tricky, distinguishing where the tumour stops and where vessels coming into and around the tumour are. And that's something that hopefully people will get more familiar with practice. But just, I think, something to be very wary of when you're starting out contouring in this situation. So going on to think about organs at risk, the one that people have found most difficult may not be surprising, and that's the brachial plexus. So in this sort of instruction pack, it was asked that you contour brachial plexus, each brachial plexus separately. The contours start from the foramen of C5, 6, 7, 8, and T1, and terminate in the region of the medial limit of the second rib. Suggested that you use a diameter tool of 5 to 6 millimeters and start contouring at the foramen and then continue out. Remembering that the brachial plexus tends to go through the space between the anterior and middle scalene muscles. These instructions were modified a little bit, I think, as we went along, because it was realized that it was actually very difficult to see the brachial plexus itself and centres were advised that they could use the vascular structures, the subclavian neurovascular bundle, as a surrogate, and then continue, as we said, to the sort of first, second rib that would serve as the sort of lateral limit of the brachial plexus structure. So what was found was, I think, that in most cases, the brachial plexus structure is under-contoured. People, and I think understandable for people of a thoracic disposition, struggled to know where the scalene muscles were. So their early or their higher contours tended to be a little bit posterior to where the gap between the anterior and the middle scalene muscles. And inferiorly, then people were not really contouring the subclavian neurovascular bundle, which was suggested as the surrogate to the brachial plexus. I think with experience, you may be able to start contouring the brachial plexus itself, but that, I think, is something that comes with experience, and I suspect quite a lot of experience. So using the surrogates, using the vascular structures is probably a very sensible thing, certainly in your first few years of delivering SABRE treatments. Every now and again, the plexus structures were over-contoured, this being an example. Moving on to proximal bronchial structures. So the instructions here were to contour using mediastinal windows and to include the cartilage in your structure. The tracheal proximal bronchus border has been set at 2 centimeters above the main carina. And then you contour proximately to include the lower part of the trachea, the carina, the main stem bronchi, right, left, upper lobe, intermedius, lingular, middle lobe bronchus, and the lower lobe bronchus. The contouring of the bronchus should be ending at the site of the segmental bifurcation. And what probably is needed when you're contouring this structure is the ability to switch from mediastinal windows into lung windows, particularly when you're getting towards the segmental bifurcations. They're much easier seen on lung windowing. So here the experience, I think, was mixed. So we saw examples of both under-contouring and over-contouring the structure. The thing people, I think, found most difficult was identifying these segmental bifurcations and either taking the contour up to them, or in some cases, the contour would extend past. Again, people were not terribly good at the junction between the trachea and the main bronchus. That was often placed incorrectly. Another example here, I think, is probably an example of under-contouring. So if you take the red as your sort of gold standard, here you see someone has probably been contouring the internal volume of the main bronchus, so the airway itself rather than the bronchial walls. I think that's just something to be wary of and to try and remember as going forward. Thinking next about the heart and the great vessel outlining. Again, the suggestion is this is contoured in a mediastinal window setting, and the heart contour is something that we've been doing for long periods of time now, and you're essentially contouring the pericardial sac. The great vessels are contoured to include the walls and the muscular layers. So again, you're not just contouring the lumen of the great vessels. Heart border superiorly should be to include really the top of the pulmonary artery. Inferiorly, the heart border is the apex where it's starting to blend into the diaphragm. Major vessels should include the inferior vena cava, and the pulmonary arteries should be excluded below the main bronchus. So the difficulty that we saw here was really the superior aspect of the heart, bringing that contour up to the top and include the top of the pulmonary artery. And to remember that the pericardium does encompass some of the great vessels. So there's an area where the great vessels are still within the pericardium and therefore within the cardiac volume. So these illustrations, I think, show that. So again, you've got the red contour as the pericardial contour, and you'll see that some centres have contoured the vessels separately and used a great vessel structure rather than the heart structure. So a similar sort of illustration. So again, red is contouring the pericardium, and again, you're seeing that in yellow, the cardiac volume that had been submitted here is under-contoured, and in the orangey colour there, they've contoured some of the structure as a great vessel. Esophagus and tracheal outlining was generally good. The advice was again to contour mediastinal windows, superiorly to be starting at the bottom edge of the cricoid cartilage, and then extending that contour down to 2 centimetres above the main carina. The esophagus needed to be contoured to ensure that all muscle layers, the outer facet adventitia, were included. Again, starting at the same superior point, lower edge of the cricoid cartilage, and continuing down to the gastroesophageal junction. So in general, we saw lots of more minor deviations. They tended to be under contouring. So you're tending to have slightly smaller volumes, the full muscle wall not being included. And I think that was for both esophagus and for trachea. A couple of examples there, again, the red being the sort of gold standard and the yellow being some of the submitted contours done by members of centres. I think it's probably a little more clear on the tracheal illustration, where you see in this example, the red does include the tracheal wall, whereas the yellow contour there really has contoured around the lumen. So I think I will be drawing to a close at that stage. The only other thing I've been asked to mention is in terms of lung contouring, which was generally good, often because I suspect that's automatic, but some centres did still include within their lung contour the ITV, the hilum, the main bronchus. Those structures do need to be excluded from a lung contour. So I think at this point, I shall hand back to Fiona. Thank you very much.
Thank you very much, Matthew, and for such a concise overview, and also to Patty, even though she's probably not on the call, for all those lovely pictures she's provided. I mean, clearly this is, I think it highlights the complexity of the technique we're trying to roll out around Britain, not just some of the complexity of the 4D in relation to the primary tumour, but structures that we wouldn't normally contact in the stage 3 setting, like the proximal bronchial tree and the brachial plexus. How do you think we should best ensure the quality of plans going forward now that this hopeful learning curve has got all centres quality assured?
I think it has to be through a process of peer review. I think clearly peer review within centres. So those who are developing the techniques can hopefully bring on the next generation. But I think there is probably a role here for peer review across a network, so that you have that extra expertise, and maybe you're exploring some of these new platforms, things like ProNow, that may offer you that chance to do it offline, so to speak, so that you can do your volumes, you can submit, you can call in others from the network when they have a chance just to check your volumes, and mutual learning, really.
Thank you, Matthew. We haven't actually got any questions in from the audience. Again, please, if you have got questions for Matthew, Corinne, or Liam, do bring them into the control panel so I can see your questions. Just one last question before we move on. I think part of the problem, or part of the issue, is that internationally we've got a number of different atlases, contouring atlases, whether they're different thoracic atlases or whether it's how the differences between how the thoracic people outline the brachial plexus compared to maybe the head and neck team. How much of an issue do you think this is? I know we provided our own, in this case, our own sort of guidelines, which may maybe we needed more detail in, and maybe we could revise. But how much of an issue do you think it is that we've got a number of different international atlases out there?
I think what saw through this program was that things people had been familiar with contouring, the esophagus, the heart, etc., then generally they were quite good. I think the one exception with the heart is that superior border. I think people have got used to, and I think this is an evolution of all these different atlases that have been out there. Over time, I think our superior heart border has gradually risen. And so if you learnt your sort of heart contouring 10 years ago, then you're not quite doing what is considered standard. So I think it is a process. I think we do need to try and get these atlases more joined up so that internationally we're doing the same thing. But in the terms of the UK, I think we now do have a benchmark that hopefully people are getting familiar with. And if we can stick with that, then hopefully we'll have a fairly uniform approach across at least England, but hopefully Wales, Scotland, and Northern Ireland will be joining us.
That's great. Thank you very much, Matthew, for your time and expertise this evening. It now gives me great pleasure to introduce Professor Corinne Favre-Finn, who is well known to, I'm sure, many of you on the call from the Christie and University of Manchester. Thank you, Corinne.
Thanks, Fiona, and it's a real pleasure to be with you tonight. Thanks to BTOG for the invitation. So I'm going to talk about advanced radiotherapy techniques to treat large volumes radically. So these are my disclosures. So these are some of the scenarios that I'm going to talk about. So obviously on the left-hand side, large primary tumors. On the right-hand side, tumors with contralateral lymph nodes. And then at the bottom, you have examples of patients who have at the same time large tumors, but also multiple mediastinal lymph nodes, including the supraclavicular fossa, or in some cases, even both sides of the neck. So I'm going to ask 5 questions within this talk. The first one is, what is the impact of volume on prognosis? And the very first study that I'm aware of that looked at the impact of tumor volume on prognosis is this prospective study from BTOG that included over 500 patients with stage 1 to 3 non-small cell lung cancer treated with curative intent. And what they showed, as you can see from the graph on the left-hand side, is that the tumor volume is a prognostic for survival. That was the case certainly in a univariate analysis, but when they adjusted for other factors such as the T stage, this was not significant anymore. They also looked at the impact of tumor volume according to the time from treatment, and they showed that the larger volume adversely affect outcome only within the first 18 months, and that is the graph in the middle, not after 18 months. And the overall conclusion of this paper is that larger tumor size alone should not by itself exclude patients from curative chemoradiotherapy treatment, which I completely agree with. Now, we do have some very good data from RTOG 0617, so you will all be familiar with this study, which was actually updated in JCO in 2019, including an update for multivariate analysis, which showed that one of the most strongly prognostic factor is the PTV, as well as the heart D5. And it's important to say that they went through an exercise of recontouring all of the hearts centrally to perform this analysis. And as Matthew pointed out, there can be major variation, which they did observe in this study. So with a uniform way of contouring the heart D5 is also very prognostic, as well as the PTV. And then in Manchester, we have done over the last few years a lot of research on the impact of dose to the heart. And we have identified in this large image-based data mining analysis of over 1,100 patients treated with 55 gray in 20 fractions, that the dose to the base of the heart is associated with poor survival, but also in this series, the tumor size was associated when taking into account other confounding factors with poor prognosis. The second question that I'd like to ask is, what is the outcome of patients with large volume disease treated radically? So we have a series from the Netherlands, a retrospective series, single center of stage 3 patients treated with chemoradiotherapy, concurrent chemoradiotherapy. They define large volume as PTV of more than 700 cc, and in this group of almost 100 patients, they had also N3 disease, and they also looked at a smaller cohort of 23 patients with N3 disease, but this time PTV of less than 700 cc. And you can see on the graph on the left-hand side, the patients with PTV of more than 700 cc with or without N3 nodal disease had a significantly shorter overall survival compared to patients with smaller volume disease. And you can see the corresponding median survival. Similar results when they looked at a cohort of only stage 3 patients. What is interesting from this analysis, however, is that they show that long-term survivors with PTV of more than 700 cc were observed. 24% of those patients without N3 and 37% with N3 were alive at 5 years, which shows that actually, radical intent treatment can be beneficial. Now, you may ask the question of what's the impact of these treatments on toxicity? Well, as expected, a third of the patients developed severe esophagitis, and 7% of the patients sadly died as a result of their treatment. All of these deaths were in patients with a PTV of more than 700 cc. The third question I would like to ask is, should we treat patients with large volume radically? We know that radical intent treatment obviously leads to better control, but we have to take into account obviously the impact on normal tissues. And we have very compelling data from the meta-analysis comparing concurrent to sequential chemoradiotherapy and an RTOG pool data analysis of 7 trials that improve local control correlates with improved overall survival. And clearly, by treating patients radically, there is a better chance compared to palliative treatment to achieve this local control and therefore to improve survival. And actually, many of you will be aware of the very sobering results of the National Lung Cancer Audit that showed that 2/3 of the patients with stage 3 disease receive either palliative treatment or no treatment at all. So, clearly difficult to achieve local control and improvements in survival. Now, the good news from the 2019 audit is that there was an increase in the patients treated with chemoradiotherapy in the use of concurrent treatment, so 54% compared to 34% in 2016, but sadly, only 6% of all stage 3 actually receive concurrent chemoradiotherapy. And also from this National Lung Cancer Data Audit, we have no data on GTV or PTV, and it would be very interesting and informative to know whether these patients who are not treated at all or receive palliative treatment are those with large volume disease. So the message is clearly no, or palliative treatment means no local control and means poor survival. My fourth question is, how should we treat large volumes, and what is the impact of advanced techniques such as IMRT? So I probably don't need to tell this very distinguished audience that IMRT compared to 3D conformal radiotherapy achieves more conformality, partly to complex geometric targets, and also a sharper radiation dose gradients between tumor and normal tissues, resulting in lower toxicity. And if you're interested to read more about IMRT, this is a nice paper from our group, which demonstrated the advantages of IMRT, as you can see in the left-hand side column, which are very pertinent to those patients with large volume disease. Now, obviously, we can use fixed beam IMRT or we can use volumetric IMRT. And you can see on this slide a comparison in a patient who has very large volume disease of IMRT versus full arc versus partial arc. And I'm sorry, the red boxes have moved. But essentially, with IMRT, with arc therapy, actually, the percentage of dose that covers 95% of the volume can be increased compared to fixed beam IMRT. And with regards to dose to the normal tissues, we can achieve a reduction in the dose delivered to the spinal cord, dose delivered to the heart, reduction in V30 and V40 with full arc, partial arc. But that is at the expense, as you well know, of the low dose path, so higher dose delivered to the lungs of the V5, the V10 will be higher, particularly with full arc volumetric therapy as opposed to fixed beam IMRT. So what data do we have supporting the impact of the use of IMRT? So the best data available is from RTOG 0617. In this study, just under half of the patients received IMRT. And despite the fact that there were more unfavorable tumors in the IMRT group, as you can see from the table on the left-hand side, larger PTV and also more patients with stage 3 disease in the IMRT group versus 3D conformal radiotherapy groups. So despite that, there were less patients developing grade 3 pneumonitis, and the dose to the heart B40 was lower in the IMRT group compared to the 3D conformal radiotherapy group. And what's also very reassuring is, again, in spite of the unfavorable tumors in the IMRT group, no difference in progression-free survival or overall survival. They also demonstrated that fewer patients who received IMRT had clinically meaningful decline in quality of life when using the FACT lung cancer subscale with IMRT compared to 3D conformal radiotherapy. And in this paper published in 2015, they demonstrated again in a multivariate analysis of overall survival that PTV is very prognostic, as well as the baseline quality of life score. Now, we presented at BTOG several years ago data from the Christie on the impact of the introduction of IMRT, and we've now updated this series, which has not been presented yet. So we now have over 12,000 patients, so that's proper big data, treated between 2005 and 2020, grouped into 3 time periods. So the first time period was pre-IMRT, second one, we had some availability of IMRT, and we selected patients based on volume of disease, but also proximity to organs at risk, such as the spinal cord. And then third time period, full access of IMRT. And you can see a very big impact on the treatment intent in the graph on the left-hand side, a reduction in the proportion of patients treated palliatively, and a big increase in the proportion of patients with stage 1 to 3 disease treated with curative intent radiotherapy, an increase from 40% to 83%. And at the same time, we saw that the volume of disease that we're treating over the 3 time periods has increased. So I guess now the big question is, what is the impact on survival? And if you're interested in that, we will be presenting some data at BTOG 2022. Now, my 5th question is, can we improve the outcome of patients with large volume using advanced radiotherapy technologies? And that is my last question. So one of the exciting area is MR-guided radiotherapy. So MR-guided radiotherapy allows better soft tissue definition with the potential to reduce the margins and therefore toxicity. But what is very exciting is the scope for frequent adaptive radiotherapy. So as illustrated by this animation, so there's a scope as a tumor reduces in volume to adapt to shape and reduce the volume treated. Now, clearly, this needs to be the feasibility, but also the impact on the local control and toxicity needs to be tested in clinical trials. And then obviously we have two proton centers in the UK. The UCL Proton Center will be opening this month or next month, I believe. And we do know from the phase 2 study of proton versus photons done in the US that we can reduce the dose to the heart with protons. So in terms of patients with large volume disease, we have two potential objectives with protons. Could we reduce the dose to the heart, which we know from our analysis and others that it could have an impact on survival, but also could we reduce the integral dose, which could reduce the risk of severe lymphopenia, which we know is an adverse prognostic factor. So a very nice planning study comparing standard plans with protons and photon plans, applying some cardiac avoidance strategy, was presented by Catherine Banfield at ESTRO 2021, showing that a dose reduction to the cardiac avoidance area, which is the top of the heart, can be achieved with both protons and photons. The D1cc to the cardiac avoidance area was not significantly lower when using protons, but the mean dose to that area was. Now, in terms of large volume disease, we also have to bear in mind that the proximity of the ITV to the cardiac avoidance area dictates whether a dose reduction can be achieved with protons. And if you have a large tumor, it's often central, close to the heart, and it is not always possible to spare that region with protons. So we have to bear that in mind. So this is my conclusion slide. Patients with large volume disease clearly have a poor prognosis, but also we know that without treatment, patients will progress and die. So we have to make sure that curative intent treatment where appropriate is delivered to patients to achieve better local control and improve survival. We have a number of unanswered questions, and unfortunately, I don't have studies that really address specifically in patients with large volume disease whether it's best to give sequential or concurrent chemoradiotherapy given toxicity concerns. And then an important toxicity of durvalumab in patients who have large volume disease compared to patients who have lower volume disease. And as you well know, we have no data on that from Pacific, as the radiotherapy dose volume data was not collected. We have a lot of hope that this data will be included in Pacific R and presented at future meetings. And then finally, the future is for the integration of MR-guided radiotherapy and adaptive radiotherapy in the management of these patients, and possibly there may be a role for protons as well. Thank you very much for your attention.
Thank you very much, Corinne, and for taking us through those key important questions so succinctly. What do you think is the main barrier in the UK for getting these large volumes treated? We know that IMRT and VMAT is now technically available in all of the centres. Is it, what is it we need to do to see these large volumes getting considered for radical radiotherapy, whether that's concurrent or otherwise?
Yes, thanks. This is an important question. So we know that IMRT is now more widely available, but how is it used routinely in all patients? But I guess the biggest issue in my mind is patient selection. So when patients are discussed in MDTs and seen in clinic, some consultants may decide to go down the route of palliative radiotherapy as opposed to radical radiotherapy, and that is based on very subjective factors sometimes. So for me, the biggest issue is the issue of training, and I think having perhaps discussions through BTOG or other forums, but Matthew also mentioned the Prono platform, where we may be able to share cases, is probably the way forward. I think for the centres where perhaps people tend to be a little bit more conservative, they need to see examples of patients with large volume disease who can be one, safely treated, so the dose to the organs at risk can be met, but also understand that some of these patients will have long-term survival. So, I think the data presented from the Netherlands, for example, is very interesting, because I think there's a belief that these patients will never achieve long-term survival, and that is clearly not the case.
And then just one final question, if I may come in from the audience, asking specifically, what cardiac constraints do you use for your stage 3 patients?
Yes, so at the moment we use a sort of V30 and V40 cardiac constraint, but this is all about to change. So following the data that we have published in the last few years, and we now have defined this area at the base of the heart that includes the conduction system, the origin of the coronary arteries. So we now understand that this is the area that we need to spare. And we have a program grant that's been awarded by NIHR that will allow us to introduce a new dose constraint for this area to all of our patients. So that will start next year. And based on the data presented by one of my colleagues, Alan McWilliam, we'll have a constraint of 19.5 Gray in 2.75 Gray per fraction, or 23 Gray in using 2 Gray per fraction.
And another OAR to learn to contour.
Well, that's the thing. So we're also looking at the automatic contouring of this structure, because we are conscious that not only it will not necessarily be that straightforward, but also people are very busy, and that's adding something else to their workload.
No, that's fantastic. Thank you very much for that. Yeah, more to come. Another advert for attending BTOG 2022. So thank you very much, Corinne. I'd now like to move on to our third speaker this evening, who's a colleague of mine here at the Marsden, Dr. Liam Welsh, who is an absolute guru in all things neuro-oncology, and is going to talk to us today about the all-important SRS that we refer our patients for. Thank you very much, Liam.
Thank you, Fiona, and thank you to the organisers for asking me to talk. So I'm going to just go over my disclosures, nothing that's going to influence what I'm saying tonight. Want to cover 4 areas: patient selection, which is a big topic, and maybe there will be some questions about that. Specifically then, radiosurgery for brain metastases in the oncogene addicted population. Delivery platforms, which is again a bone of contention that never seems to disappear, but maybe we can say something constructive about that and reassuring about that. And then some brief remarks on radiosurgery complications. As we treat more patients, we'll see more complications arising, and also the difficult issue of how to assess response. So I don't really, I'm sure I need to highlight to this audience the significant problem that brain metastases represent in non-small cell lung cancer. This population forms 40% of the workload in the radiosurgery service that we deliver, and that's a common theme across radiosurgery centres. The brain metastases being a specific issue in the oncogene addicted population, which we'll come on to. So patient selection. Radiosurgery services in England were recommissioned by NHS England in 2015. 17 centres were commissioned to provide access to intracranial radiosurgery, recognising that access had been inequitable and patchy. This process, I think, has resulted in an improvement of access. Centres went through a benchmarking process, a little bit like that Matthew outlined for thoracic SABRE, but different centres will use different platforms, and there is still a variation in practice. My own practice covers 2 neuroscience networks, so we've got a catchment population over 4.5 million. We've treated more than 1,400 patients since we were recommissioned in May 2016. And as I say, about 40% of all those patients have non-small cell lung cancer. So as we have increased access to radiosurgery, which was part of the plan, naturally there's been a decline in the use of whole brain radiotherapy. These are data from the Marsden. The whole brain still has a place, So as you can see, it hasn't disappeared entirely, but there has been, I think, an entirely correct crossover. So in terms of who can access the service, NHS England stipulated these specific criteria, which are pragmatic and I think quite generous. They're not really based in hard evidence, but nevertheless, there needed to be some basis for deciding which patients would potentially benefit from an expensive and complex intervention. So we've got a performance status category, we've got a life expectancy greater than 6 months as estimated by the primary tumour site oncology team looking after the patient. We need to have a situation where the extracranial disease is either absent or controllable. Obviously, that's something that is quite soft, but essentially that means we've got to have at least a further line of systemic therapy available. And then there's a stipulation on the total volume of brain disease that should be less than 20 cc's in total. But as you'll notice, nothing about the total number of brain metastases. So this has been a perennial issue in radiosurgery. How many is too many? Nobody knows the answer to that, I don't think. There has just really been a technical limitation. These are some old data from the Japanese Gamma Knife Society, treating patients with up to 10 brain metastases. 3/4 of the patients in this study had non-small cell lung cancer. So what this very clearly shows is that having only a single brain metastasis confers some survival benefit, but having more than one, it doesn't really seem to matter how many more than one, it doesn't make much difference. And I think that is the reality. So stipulating a sort of specific arbitrary upper bound on the number that can be treated is always going to be problematic, and it's really just a technical issue rather than an oncological issue. But my own experience, these are data that need updating, and I'm sorry I didn't have time to do that for this meeting. So they relate to the situation at Marsden up to 2 years ago. So what we can see here is overall survival for non-small cell lung cancer patients treated with radiosurgery on the left, and then stratified by the number of brain metastases. So very similar to the Japanese data. Having one is prognostically good. How many more than one doesn't really matter. Volume makes a bit of a difference. So having small volume disease is prognostically favourable, and larger volume diseases one might expect less favourable. So volume matters more than number, and obviously you know the NHS England criteria make some allowance for that. So if we turn our attention then to the oncogene addicted subset, so just passing over this very quickly because you'll be more familiar with these data than I am, but essentially what we have now for the ALK-rearranged patients, to some extent the ROS1 patients, is highly active tyrosine kinase inhibitors, which in the first line setting show very high response rates. So with brigatinib here, in this study, maybe a response rate in the brain of about 80%, and with alectinib, even better than that, maybe 90-odd%, and then a brain protecting effect with patients without brain metastases on alectinib. So potent intracranial activity, and obviously this is now a consideration in selecting patients for radiosurgery, and this is essentially unresolved. So for our own patients who have had radiosurgery for ALK-positive non-small cell lung cancer with brain metastases, we're seeing a better than average survival, and there's data that have been seen in other centres as well. You know, this is an important population who can potentially do extremely well with a combination of tyrosine kinase inhibitor with maybe radiosurgery held in reserve as necessary. So that's now a very special population. For the EGFR mutant, things are slightly different. These are old data that suggested that upfront radiosurgery was better than upfront TKI for patients with brain metastases, but of course these data predate the advent of osimertinib, with, as you know, again, a very high level of intracranial activity in the first line setting. So bringing then the role of osimertinib and radiosurgery into question. Our own data for survival after radiosurgery for brain metastases in the EGFR mutant population somewhat less favourable than ALK, partly just reflecting the difficulty when disease does progress on osimertinib, and radiosurgery may have a specific role in that situation to deal with oligoprogression in the brain. This is an interesting case in point that came through our MDT recently. So this is a relatively young patient who is presented with a synchronous brain metastasis, very eloquently located near the left motor strip, with a lot of edema and obvious neurological symptoms. So the question arises, do we, in this instance with an EGFR mutation, treat with upfront TKI with osimertinib, or do we go with radiosurgery? So in the end, this patient was treated with TKI, and we'll see how things go. But I think with a response rate of the order of 90-odd%, that is comparable or even better than we may see with radiosurgery. And so I think that is an entirely reasonable situation. Of course, when we're facing this kind of development for a patient who's on TKI, the considerations are different. So it is quite complex. In the first-line setting, we clearly do need a study to help us work out how to integrate radiosurgery into systemic therapy for patients with oncogenic driver mutations. So we've really needed a study to address this. So we're fortunate in as much as I think this very flexible and broad scope ETOP STRIKE trial may help address this. So this will encompass patients with non-small cell lung cancer with driver mutations who will be allocated either to systemic therapy or systemic therapy with radiosurgery. So we're really hopeful that that will open and help us understand how to integrate these treatments together. So moving on to delivery platforms. In my practice, we primarily use a CyberKnife platform. We have 2 of these machines now, and we've been using the one in the picture now for 10 years. It's proved to be very flexible, and of course it can be used for SABR as well as intracranial targets. I think all radiosurgery centres potentially benefit from having access to a dedicated radiosurgery platform. These are particularly useful when treating small volume sites of disease with high accuracy. So that could be a Gamma knife or a CyberKnife. But we'll come on to LINAC-based platforms in a moment, because there are means by which we can deliver high-quality radiosurgery using standard gantry-based LINAC. So essentially all centres should be able to deliver multiple metastases brain radiosurgery. This is a case in point. This is a 26-year-old man with 17 small-volume brain metastases with a ROS1 mutated non-small cell lung cancer underlying. The total volume of disease here is only 4 cc's. It's quite hard to see most of the metastases. That's sort of the point, but some of them are in quite eloquent locations. This patient received radiosurgery to all 17 sites, 658 beams on the CyberKnife with a 3.5-hour delivery time. Was extremely well tolerated, and this patient was someone I treated more than 5 years ago and remains fit and well. So radiosurgery can be highly effective. This is an example of that patient's plan, showing the hedgehog in the top left, which represents a cluster of the beams that were used, and you can see some of the dose distribution. The treatment is ideal in this kind of scenario, but for a young fit patient, they're easily able to tolerate a substantial delivery time, and of course it leaves a lot of flexibility for the future. Here's our old, this was our oldest LINAC, but it was able to deliver some of the most advanced radiotherapy. We're in combination with a BrainLab ExactTrack system that can be retrofitted to pretty much any LINAC, which gives a real-time image guidance system, which in conjunction with some software can allow us to use multiple non-code planar arcs to deliver very rapid treatment to multiple brain metastases. This platform can now deliver treatment for 20 plus metastases in less than 40 minutes. It uses, as I say, dynamic non-code planar arcs to treat multiple metastases in sweeps of the gantry. And it has pretty much an automated planning system, making it quite easy to use. And this was used with a machine with only a 5mm MLC, so you don't even need a micro MLC. Because of the dynamic nature of the treatment delivery, it's not all that sensitive to MLC leaf width. So really, if you can get that to work on an ancient LINAC like that, really any centre with a bit of investment can deliver radiosurgery. In some situations, the dosimetry won't be quite as advantageous as, say, Gamma knife or Cyber knife, but for many patients, it will be delivering a very good treatment. There is a dose response element to radiosurgery. These are ancient data demonstrating just that, with a marginal dose of 24 Gray achieving maybe a long-term local control rate of about 70%. So not quite as good as some of the TKI response rates that we've seen, but this can be quite durable, as you can see from the data. In terms of the risk, as we escalate dose, we deliver more dose to the brain tumor tissue immediately adjacent to the brain next to the target, and of course then there is a risk of causing damage or brain radiation necrosis. That is correlated with the local V12, and so when we're planning radiosurgery, we look at the local V12. This is more or less a per lesion metric, where you've got metastases clustered together. We may see some bridging, and then we do need to look at the local V12 in the cluster. So this needs some attention, and you can see that the V12 here is associated with the risk of radiation necrosis in these data from Giuseppe Minetti in Rome. So this is something that needs to be looked at, and sometimes we do need to reduce dose to accommodate the risk of radiation necrosis. Just to show an example of what can be done with a pragmatic approach, the top two scans here show a brain MRI scan for a newly diagnosed patient, a 52-year-old woman with a wild-type non-small cell lung cancer with a hemorrhagic brain metastasis and a number of small volume additional brain metastases, 17 in total. That hemorrhagic lesion, it's very difficult to discern what's blood and what's tumour. The lesion itself in total is about 20 cc's. The patient had been turned down for treatment at another centre, but we felt we could treat her using a fractionated radiosurgery approach, which is readily deliverable on the CyberKnife or LINAC platform. So we did so, 3-fraction radiosurgery, including that hemorrhagic site, just treating the entirety of the volume. And the result there at 3 months is shown below. The patient is actually entirely well, coming off steroids with no deficit, with significant regression in the hemorrhagic site, and presumably the tumour in there somewhere also regressing. So just really to illustrate that even difficult situations can be tackled, and if you don't get a sensible answer or a satisfactory answer from your local MDT, it can be worth asking around, because experience does vary. So radiosurgery complications. First thing I just want to mention is scan frequency. So for patients with brain metastases, it's worth monitoring. This is a patient with an EGFR mutated non-small cell lung cancer who developed a pontine metastasis. You can see there on the right, that is easily treatable with single fraction radiosurgery, but it's best treated when it's small, as you may appreciate. So NICE have produced some recommended follow-up guidelines. So 3-monthly brain MRI, I think, is right. And I think really for the longer term, that is probably the right thing, although NICE have recommended backing off a little bit as time goes on. But I think the evidence for that is weak. But 3-monthly scans, I think, is sensible. Problem solving. Well, sometimes the scans that we do at follow-up are difficult to interpret. This is a patient with a right occipital metastasis. This was treated with radiosurgery. That's the state of the disease at the time of treatment in September 2017. So the following year, we've got a situation on the right. Is that recurrence or is that radiation necrosis? Can be very difficult to determine. So a technique called contrast clearance analysis can be helpful. This looks at the kinetics of contrast clearance on follow-up brain MRI scans. Essentially, we do a post-contrast scan 5 minutes and 1 hour after injection of contrast. Radiation necrosis will show delayed clearance, whereas tumor will show rapid clearance, and these are color-coded on a subtraction difference map from the MRIs at 5 minutes and 1 hour. That's shown here. So blue is bad as per histology, and in this particular case, we can see that tumor was showing rapid contrast clearance compatible with progression or recurrence. and that was confirmed then when the patient underwent neurosurgery for resection of the metastasis. So a local failure that was confirmed before surgery. So in summary, there are now potentially effective systemic therapy options for all groups of non-small cell lung cancer patients, but particularly those with driver mutations, and that needs to be taken into account. And so really to manage patients and to get the optimal selection, we've got to work together. That means the lung MDT working together with the neuro-oncology MDT to decide how best to proceed and integrate the available treatment options on an individualized basis for each patient. There are many open questions, not least of which is the timing of radiosurgery and how to integrate with targeted therapies and immunotherapy, which we've not touched on. There's the open question of screening and the remaining outstanding role of does whole brain still have a place at all? So I'll stop there and take any questions.
Thank you very much, Liam. That's fantastic. It's lovely to see all the advances with SRS pretty much replacing most of whole brain radiotherapy, and now with systemic therapies getting so good, possibly moving SRS out of the frontline space, and clearly highlighting that ETOP strike trial will be very interesting. Haven't got any questions in from the audience as yet, but knowing how much we rely on the follow-up and your interpretation of fancy scans, how widely available, given the resources of asking patients to hang around for an hour, how widely available across the UK are these tram scans?
Well, there are other centres that have introduced them. I know that they're using them, for example, in Cambridge and Plymouth. Of the types of advanced imaging that can be used to try to distinguish between local recurrence and brain radiation necrosis, they're relatively resource light. Traditionally, perfusion imaging or even spectroscopy has been done, and that is really resource intensive, and most centres just can't get that done. And then the neuroradiology input required to interpret the imaging is considerable. So a tram scan will tie up a scanner for an hour because typically there isn't time to get another scan done between the two imaging sessions. So it does lock down the scanner for an hour. But other than that, the technology is just some software. The scan sequences are just very standard volumetric contrast sequences that can be done on any MRI. And the software is largely automated. So it is something that is logistically relatively straightforward to do. And, we've been able to introduce these at the Marsden without any great difficulty in an imaging department that is extremely busy and under a lot of pressure, as you know. So I think as advanced imaging goes, it's pretty manageable. Of course, it's not perfect, and there are questions of interpretation. We found these scans pretty useful for non-small cell lung cancer patients. They are much less useful for patients with, say, mucinous GI tumours, where actually the tumours intrinsically show delayed contrast, and so it's just not useful. So you can get false negatives. They're not perfect, but then nothing is, and we have found them quite helpful in situations where we have delivered a lot of treatment and we're not sure, whether we are looking at a problem or not. And we've often had reassurance from the tram scans, which has been borne out over time. So they're not generally available, but they could be, I think, quite widely available if there was interest.
Thank you very much, Liam. There is one question for the audience, but it might not be fair for you, Liam, as it's more to do with the management of lung disease in general. I'm not sure if Matthew or Corinne are still on the line, but should patients with 1 or 2 brain metastases, but otherwise radically treatable thoracic disease, be treated radically with brain SRS and then radical thoracic radiotherapy? I see Matthew turning his mind, and Corinne, they're both popping back. Do either of you want to take that question?
My suggestion would be consider a Sauron trial. Metastatic disease.
Yeah, I think I love your answer, Matthew. I think the Sauron trial requires you to have at least one other met outside of the brain. But yeah, absolutely, that needs to be at the forefront. Corinne, do you treat these patients with radical thoracic radiotherapy?
Yes, definitely. So yeah, we would generally start with the SRS and then give, at the same time plan the radical treatment to the thorax. But yes, and if a patient is PS01, would consider concurrent chemoradiotherapy in this situation. If it's stage 3 within the thorax, if it's earlier stage within the thorax, of course, whatever is appropriate, it could be SABR or whatever is right.
What about if this was a mutant patient, whether it's ALK-EGFR or ROS1?
Yes, well, that is the tricky question, isn't it? And again,
I added that bit, Corinne, just for a bit of spice at the end.
Yes, well, it's, I think as Liam has outlined, there's a lot of uncertainties regarding the sequencing of these treatments. So there is no doubt that, they should be treated with the appropriate targeted therapy. But where SRS fits in and where thoracic radiotherapy fits in and in what order, I think is the tricky bit. What I understand from, certainly many discussions I have attended is that nowadays medical oncologists quite like to start the systemic treatment first, see what the response is, and then potentially offer these local therapies a little bit later. So, obviously we have the STRIKE study in the context of immunotherapy, and other studies, similar studies were discussed in the context of EGFR TKIs, but where thoracic radiotherapy fits in is a bit more unclear.
That's fantastic. So we've got the trials, some open, some to come, kind of all in this space, but still some grey areas. That's fantastic. Thank you very much to my 3 speakers. And I'm sorry this is not an in-person meeting, but look forward to seeing you and I'm sure members of the audience soon. And just before we head off, I just want to highlight the next upcoming webinars we've got for BTOG. So tomorrow morning, if you haven't got any other plans, we'd love to have you at the BTOG Masterclass leading your lung cancer team. And then the next BTOG webinar is in a few weeks, Wednesday the 10th of November, which is one of the BTOG essential updates supporting patients with thoracic malignancies. So thank you very much to all of our panel and the audience for staying late tonight. I wish you all a lovely weekend. Thank you.